So if we are talking about the different parts of structural heart disease, there's of course the aortic valve as the main center of interest. It has been since the last 12 years, since Alain Crébier implanted the first minimal invasive transcatheter aortic valve in a stenotic valve. In the industrialized world, the mitral valve is the most common disease, mitral regurgitation due to tissue failure in the prolapse or also in the course of cardiomyopathy called functional MR is the most diagnosed disease in the Western world. This might be different if we look to other parts of the world where we have rheumatic disease leading to mitral and tricuspid stenosis. And then of course we have aortic insufficiency, aortic regurgitation, but more and more coming in the center of interest is also tricuspid disease. The tricuspid valve has for a long time been called the forgotten valve because there was no option to treat. Now that we are getting more and more options, we are having minimal invasive options to treat the tricuspid valve, it gets more in the center of interest. We have to consider that 0.8% of the general population have severe tricuspid regurgitation. So it's not a small number of patients we are talking about. And then of course we have the pulmonary valve, which is more in congenital disease, but is of course also a valve that can be treated minimal invasively. Well, I think from the diagnosis we are all aware that in the traditional way, auscultation with the stethoscope is the most traditional approach. In our world and today's world, I think echocardiography is the major player. So any patient that has suspicion of structural heart disease will be referred to an echo, will get an echocardiogram, and we then will further determine the underlying course of disease, the degree of disease, and possible treatment options. The next step will be catheterization. So we have to evaluate the coronary arteries, we have to evaluate the pressures in the right heart and the left heart, and then of course CT, a CAT scan as an additional source of information when it comes to calcification, to vessel size, to degree of calcification of the valves, and further topics as the access for minimal invasive technologies. So I would say this is like the spectrum of diagnostic modalities that we need. Well, the therapy, first place therapy normally is medication. So we are giving diuretics, we might give ACE inhibitors or heart failure therapy in order to strengthen the heart muscle. Once certain parameters change or the medical therapy, the optimal medical therapy is not anymore guaranteeing the well-being of the patient, we might consider other options such as surgical repair or in the last years more and more minimal invasive transcatheter-based repair. As we are living in exciting times and have been able to witness the development of transcatheter minimal invasive heart valves throughout the last, I would say, 10-15 years, there is more and more knowledge about when to use a transcatheter-based technology safely. As we know, FDA has recently given the green light for patients with low risk and aortic stenosis to be treated with a TAVI, so with a transcatheter-based aortic valve repair. We are getting more and more data about mitral clip, which is a technology that is used in the mitral valve, in mitral regurgitation. And we are trying to get more and more technologies and more background information and data on the right side of the heart. So, as I already said, on the right side of the heart there are different approaches to use the surgical knowledge that we already have and to transfer it into transcatheter technologies, such as bringing in rings, working on the annulus, or minimizing the coaptation by clipping or suturing parts of the leaflets. There's also very promising results about the placement of minimal invasive heart valves in the vena cava superior and inferior. So I think there's a lot to come. From the diagnostics, we do need echo, but for placement of the valves, most favorably is a hybrid OR. So we do need a cath, we do need contrast, and we do need visualization by radiation just to be able to place the valve correctly. Transesophageal echo is a good aid. It's not necessary, but of course you're treating very ill patients and with a very minimal invasive technology, and the better you can place your valve, the better your results will be.